Good afternoon. My name is Siang Ten. I'm one of the medical oncology consultants. I'm also the supervisor for the oncology residents at the Royal Adelaide Hospital. I wish to show you a series of slides that tells you essentially what your role will be with the oncology unit at the Royal Adelaide Hospital. Firstly, a warm welcome to our ward resident and ambulatory resident to the medical oncology unit. We hope you have a good time working for us, and hopefully it's a great learning opportunity for you as well. First of all, we'd like to tell you a bit about medical oncology unit. So the medical oncology services comprises of outpatient clinics, the inpatient acute care, and inpatient consult services. The roles and duty of our resident officer firstly is to provide acute medical care, managing cancer-related or treatment-related complications using the medical principles that you already have. Provide psychosocial care and support to cancer patients, including participation in family meetings. We would like you to develop and coordinate discharge planning of all admitted patients. We'd like you to develop skills in working up and managing patients with a new diagnosis of cancer. We also like you to develop knowledge of a wide range of malignancies and their associated therapies. We would like you to have good communication skills and display compassion and empathy toward our patients. We would like you to appreciate the role of clinical research, which you know is very important in cancer therapy. The rotation is essentially divided into ward resident and ambulatory resident positions, with residents swapping halfway through the rotations. So just below is a box telling you the different positions or duties that the ward RMO and ambulatory RMO will be doing. For the ward RMO, your key duty is managing the inpatient. We expect that you support the intern who will be working closely with you. You should present at meetings, in the morning huddle meetings, and also ward meetings, which happen twice a week. The ambulatory RMO, on the other hand, your responsibility is for admissions of patients from ED or from outpatients. Your role is to see consults from other inpatient units and also look at patients in chemotherapy day center, troubleshooting problems in the rapid assessment clinic, and assisting the ward team. Hopefully, there are many learning opportunities during this rotation for both resident medical officers, including bedside teaching, presentation at clinical meetings, and attending education meetings, including journal clubs. At the beginning of your rotation, please meet with your term supervisor, which will be me, to determine and define your learning goals for this rotation. The head of unit is Dr. Harminder Thakur, and the consultants in the medical oncology unit is split into 3 streams. We like to call ourselves different colors. So the gray team, pink team, and the green team. So just to introduce the names of the consultants, Dr. Harminder Thakur, who's the head of unit, Dr. Nimit Singhal, Dr. Siang Ten, who's myself, and Dr. Jonathan Hogan-Doran. The pink team is Dr. Sid Silva, Dr. Nicholas Murray, Dr. Mina Okira, and the green team is Professor Michael Brown, who's also the head of clinical trials, Dr. Ann Taylor, and Dr. Brian Stein. And underneath us, we work closely with our registrars. I'm not going to elaborate too much on this slide. You might want to pause and have a little read through, but you can see that with each color, we have our own specialties. Please do note that Dr. Ann Taylor also has an interest in breast cancer, and Dr. Sid Silva, lower GI cancers and also sarcoma. I'd like to introduce the duties of the ward RMO. So you start work at 8 o'clock, finishing at 16:30 hours from Mondays to Friday. And every second Saturday, you participate in ward rounds, which starts at 8 to 11 o'clock or thereabouts, followed by cover shifts from 11 to 9 o'clock in the evening. Your daily roles and responsibility include the management of all ward patients, providing acute medical care, discharge planning, involving yourself in family meetings, which is very important, and you have to support our intern as well. We do expect that you prepare and present for 2 meetings. One is the morning huddle meeting that happens from Monday to Friday at 8 o'clock every day. Oncology ward meeting, which happened twice a day on Mondays and Thursdays, presenting current inpatients and discussing issues and treatment plans. We'll go into more detail of that later. The ward RMO is responsible for inpatients during working hours and work directly with the on-call ward consultant. The ward RMO is supported by the ward consultant, and please ask for help if you need help. Ward consultant changeover takes place weekly every Thursday at 1 p.m. after the ward meeting. Please approach the registrars as well if the consultant is not available. Daily ward rounds are mandatory for all inpatients that you see with the intern. Of course, if there are new patients that's unwell or has complex care needs or with difficult social situation, the consultants would be more than happy to see in the morning. Now, the morning huddle meeting, the aim of this meeting is to facilitate discharge planning involving allied health and nursing colleagues. Starts about 8 o'clock in room level 6E031. You cannot miss that meeting because it's the meeting room next to the ward clerk in the entry to the ward. Happens every morning, Monday to Friday. It holds roughly about 30 minutes. It's attended by the ward consultant on call, the ward RMO and intern, allied health including social work, occupational therapy, physiotherapy, the nursing team leaders will be there, and the overnight RMO will be there as well. We do encourage consult RMO to attend if they have admitted patients the day before, and clearly they would know more than the other home team. Night resident medical officers should present new admissions and discuss any overnight issues with inpatients. So that is also a time where we do our formal handover with the night team. We do ask you to focus in the morning huddle. The meeting should be aimed at allied health, concise medical and social background, address the key active medical issues without going into too much details, and involve the allied health team and discuss their concern. This is the opportunity for us to have a one-to-one interaction with our allied health colleagues. We use it as part of a discharge planning. We incorporate the estimated discharge date, or EDD, and we try to identify barriers for discharge. Brainstorming is certainly encouraged for discharge planning. The oncology meeting is different. It's more medically focused. We present all current inpatients to develop medical treatment plans and discharge planning. Happens at 1 o'clock on Mondays in level 3 this time in the big meeting room 411. And on Thursday it happens in the same room as where we have our morning huddle. This meeting is attended by most of the oncology consultants who are present and their registrars, the ward team and palliative care colleagues. It can be used to address medical concerns, especially if the patient treatment consultant is present. Some tips to presenting at the ward meeting. Try to identify and know your patients well. It's more thorough presentation is expected. Be prepared to answer relevant medical questions. We suggest that you consider the ISBAR methods, and more details on the next slide. Please remember to update the OASIS handover each day, noting the treating oncologist, the patient's oncology diagnosis, including histological and molecular characteristic. I'll give you three examples. For example, in breast cancer, we expect that you know what their ER, progestogen, and HER2 receptors are, and what the size of the tumor is. In prostate cancer, I expect you to know what the Gleason score is, if available, and what the initial PSA and the PSA trends are after each therapy. In lung cancer, for example, the type of cancer, for example, adenocarcinoma of the lung, what's the status of molecular status, for example, EGFR, ROS, are they wild type or do they carry a mutation, and what their PD-1 status is and how many % is expressed. We expect you to document any anti-cancer therapy and which cycle numbers are present, any previous radiotherapy history, for example, 20 grays, 5 fractions to the lumbar spine. The ISBA presentation has got 5 parts. First of all, identification, so ECOG status, brief social history, including family community supports, and the level of self-independence. Situation, the presenting issues, what's the background, oncological diagnosis, treating oncologist, what's their active treatment and the date of last treatment or the last cycle of chemotherapy, for example. What's your assessment, the list of current active issues and problem lists, and what's the recommendation, treatment plan, and discharge. So please know your patient well. 7 steps and resuscitation discussion is of paramount importance, and if possible, and sometimes it's not possible, we do understand that. Try to ascertain that from the patient on admission. Please do consider every patient to have DVT prophylaxis, aperients, antiemetics, and pain management. Step for management: why are they in pain? What sort of acute analgesia requirements are needed? And why is the patient using high volume breakthrough opioids? And if they are requiring high volume of breakthroughs, please consider starting long-acting agents. And also, is there something that we can irradiate or offer radiotherapy to reduce analgesia requirement? Please also don't forget patient who gets oxygen on admission. Why are they still on oxygen? Could they be weaned off, or should they be discharged on home oxygen? Please do consider any barriers of affecting discharge, for example, the need for home equipment, access to home services. Don't forget, a lot of our patients sometimes have high calcium, low cortisol, or abnormal thyroid function tests if their symptoms of unwellness is pretty vague. Now to the ambulatory RMO section. What are your duties and responsibility? You have the similar hours of duty as the ward RMO from 8 to 16:30 hours Monday to Friday. Every second Saturday ward round starts from 8 to 11, followed by cover shift from 11 to 2100 hours. Your roles and responsibility is admission from EDs and outpatient clinics. You see consults, see the new diagnosis of cancer, and provide clinical support for cancer patients admitted to other units. Sometimes you do have to meet with the family. Of course, do involve your consultant. Chemotherapy day centers, you do have to attend short calls or troubleshoot any problems. I've mentioned earlier on the rapid assessment clinic. You provide clinical assessment of unwell cancer patients in medical oncology. And try to assist ward team if you do have spare time and if there is a lot of inpatients. For admissions, ambulatory RMO is the first on call for ED referrals from Monday to Friday, 8 to 5 p.m. Do contact the ward consultants to discuss the case in the first instance, especially if you're unsure. Expected details in admission notes, of course, the diagnosis, which stage the cancer is, histological molecular characteristic that we mentioned on, who is the patient known to in terms of their oncological treatment, who's the consultant, and where do they have treatment? Are they a public or private patient? The full treatment history and functional status, the date of last systemic therapy and radiotherapy history. All patients need to have documented resuscitation status, including the 7-step pathways. They need to have a VTE prophylaxis if no contraindication, and PRM medications charted for pain, aperients, antiemetics, and laxative in some cases. The admission criteria: any patients undergoing active cancer therapy, active surveillance by the cancer unit should be admitted to the cancer services for a cancer-related problem, and in other cases as appropriate. There are, of course, exceptions to rules, even though they can be the oncology patient, but if they need acute intervention and monitoring, such as massive gastrointestinal bleed, acute myocardial infarction, chest pain for investigations, pleuroeffusion, pericardial effusion that requires drainage, we do like to consult the primary other teams first before they come under oncology. Advice on admission: in case of where malignancy is suspected but diagnosis has not been confirmed, i.e. no tissue diagnosis, we try to refer to relevant specialty team that are able to expedite the diagnostic workout. Private oncology patients, we should try to endeavor to contact their private oncologist first. If there's a radiotherapy patient where there is no other cause for the problem, they should be admitted to radiation oncology. For example, spinal cord compression that requires radiotherapy that's not for neurosurgery should go under radiation oncology. Patients should be considered for ICU or HDU admission, especially if the goal of care is curative. But when uncertain, please do discuss with the consultant on call or the relevant registrars. This is probably quite self-explanatory based on what I've said already. I'm just going to skip that. You can read that on your own time. For consults, ambulatory RMO is the first on call for consults from Monday to Friday from 8 to 5 p.m. This may be in the form of formal bedside consult or phone services. One approach is to prepare before seeing the patient, read up on the case, seeing and assessing the patient, then present the patient to the consultant with the appropriate tumor stream, follow-up and coordinating management after discussion or being seen by the consultant. Please do ensure before you see a cancer patient, especially if they're newly diagnosed, that the home team has informed the patient, or if they have been at least know that they have got a cancer diagnosis. You should try to see what the histology, molecular testing and radiology is possible. If possible, try to stage the disease according to the 8th edition AJC CTNM criteria. Determine the intent of treatment. Is it curative or palliative? Does the patient have localized disease or metastatic disease? We need to assess whether other teams need to be involved, for example, radiation oncology or palliative care. Discuss the case with the registrar, especially when you first started, before you talk with the consultants. When you see and assess the patient, try to get adequate social history and support and determine the level of independence. Try to get a detailed history of the symptoms that led to the diagnosis, including the current cancer symptoms. Try to ascertain the patient's understanding of their cancer diagnosis. Medical history, including comorbidity, smoking history, alcohol, and any drug allergies would be of paramount importance. Physical examination, including height and weight, and their ECOG status is also important. Communication skills and compassion are essential in taking history from an oncology patient. Present the patient to a consultant with relevant tumor stream. We'll show you on the next slide who does what. I've shown it to you already prior to this. As your knowledge develops, also consider what treatment options and come up with a short treatment plan if possible. This is an opportunity to develop your clinical skills and knowledge in oncology, as well as to hone in on your skills for long cases. Helpful clinical resources, they're all available online, is the ESMO Cancer Guideline, NCCN Guideline, and the AVQ New South Wales Cancer Network. Don't forget that sometimes follow-up and coordinating management, you may have to arrange additional tests, booking treatments, or outpatient clinics, and communication with home team is important. This slide is self-explanatory, gives you the color of the different consultants. You notice that the grey team has 5 consultants, and we do see quite various types of cancer. Myself, I am part of the grey team, and I see only genitourinary cancers. Some inpatient consult may need to be seen urgently on the same day. For example, new diagnosis of small cell lung cancer, patients who is very unwell with high disease volume and critically unwell even without the benefit of tissue diagnosis. Rural patients may require complex care coordination, cancer of unknown primary that needs upfront input from medical oncology, new diagnosis of malignancy where patients or family have questions that are unable to address by the home team. Some patients may not require an inpatient review and can be referred to medical oncology or PD. For example, patients who are stable that have good performance status with a tissue diagnosis and no acute requirements, where the home team has provided appropriate information to the patients. For example, stage 3 or localized colon that's been resected that requires adjuvant therapy. They can be seen by the consultant in an outpatient if they're clinically well and ready for discharge. Also remember that we do have dedicated cancer nurse coordinators that can be involved in arranging patient counseling and support. They mainly help with outpatients. Chemotherapy Day Center is located in 3E. The opening hours is 8:30 to 5 on Mondays, Thursdays and Fridays, because on Tuesday they are open from 8:30 to 9 p.m. On Saturdays and public certain public holidays, they are open half a day from 8:30 to 1:30 p.m. and we're closed on Sundays. Ambulatory RMO is the first on call for chemotherapy day center review, and they task from Monday to Friday 8 to 5 for medical oncology patients only. Discuss cases with the registrar allocated to the CDC for the day. See the online roster. Common CDC tasks is patient review, for example, if they're just feeling unwell or have developed new symptoms and need medical review. Standard short calls, for example, pain, derange, or vital signs. Sometimes you'll be asked to do scripts for patients for supporting medications and symptom relief, for example, antiemetics, laxatives, or analgesia. I want to emphasize that pre-chemotherapy review can only be completed by consultant or their registrars. Chemotherapy can only be completed by consultants or their registrar. You cannot be expected to write a script for chemotherapy. Completing orders for treatment such as zoledronic acid, denosumab, blood products, and IV fluids can be part and parcel of what is expected, but certainly for Zometa and Xgeva, do check with the registrars if you are uncertain. Some medication authorities are required, and we do hope that you can help us. So patients sometimes require medications to be administered at home by RDNA such as pegfilgrastim or heparinase saline. Please help us write those medication orders. Rapid Assessment Clinic is located in 3E47 in the outpatient area. RAC is designed to facilitate ED avoidance and is open until 3 p.m. Monday to Friday, except public holidays and weekend. Ambulatory RMO is the first on call for the RAC room from Mondays to Fridays for medical oncology patients only. Hematology RAC reviews are covered by the Hematology Ambulatory RMO. Patients cannot be booked into RAC days in advance. Patient needs to be in contact RAC prior to presenting, and that's the mobile number that's listed there. Rapid Assessment Clinical Pathways. There is a system that happens in the RAC room. The RAC nurse often receives a phone call from the patient, and they arrange for the patient to come to the RAC room and do inform you ahead of time. The RAC room nurse can do tasks such as vitals, cannulation, bloods. They can help you organize ECG, and then your task is then to review patient to determine whether that problem can be sorted there and then, or do they need further admission to sort out their problems. Rapid Assessment Clinic, the key is having good communication with patients, the RAC nursing staff, the relevant departments, bed flow, registrars and consultants. And do be aware of the time of day and arrange ward bed early as possible, because the patient really cannot stay in the RAC room after its closure at 3 p.m. There's sometimes that you may feel that you have to multitask, and indeed this may be the case, but triaging is key and priority should be given to patient safety and their medical condition. There's an after-hours cancer RMO that starts at 2 p.m. and they can help cover all cancer services. Work together with them to complete jobs if you need help. Hand over this job if you're unable to complete within your rostered hours, for example, late ED referral. The pharmacists in the day centers are extremely useful for medications-related questions and are located in the same outpatients chemo area in 3E room 4. Do contact the registrars on relevant tumor stream for advice regarding treatment complications. Useful resources can be obtained from clinical notes that you can obtain electronically through Sunrise, pharmacy notes, radiotherapy notes, and AVQ are all extremely helpful resources. ESMO guideline that I've mentioned, NCCN guideline, there are also current guidelines on febrile neutropenia, low-risk febrile neutropenia sepsis, and up-to-date. These numbers are very helpful, so I suggest that you take a picture and store them on your phone. The Saturday Cancer Cover Shift, Medical Oncology RMO area located to the Cancer Cover Shift every fortnightly. It is shared between the ward and ambulatory RMO, so you do alternative weeks. There's no problem swapping shift with other RMOs as long as you don't work 7 days straight. Please, however, provide the oncology admin secretaries know in advance. The hours of duty generally starts from 11 to 9 o'clock on Saturdays. Ward round of the inpatients with the consultant starts from 8 to 11. Then you start your cancer cover shift, but of course, they sometimes can overlap. Provide cover for both Med-Onc and Rad-Onc patients and admit any patients for both teams. Hematology have their own specialty cover. Occasionally, you might ask to do cover jobs for the day center, which is expected. What to expect on the cancer cover shift? Vast majority are phone calls involving medical oncology patients. Example of common calls include fever, pain, review of unrolled patients, fluid orders or review, IV cannulation. You can discuss patient with on-call registrar after review. Discuss with on-call registrar or consultant for specific issues that require senior input, for example, a deteriorating patient or a patient that is involved in a med call. ED calls or referral will be directed to the on-call registrar, who might then call you to come and admit the patient. Lastly, cancer care is challenging and it's a rapidly evolving area based on evidence-based medicine and driven by clinical research. It does require astute application of medical principles that you've learned, and also showing compassion of your patient during this difficult period of their cancer journey. There are many learning opportunities during this rotation, and we hope that it will be a very satisfying rotation for you. You'll be supported by consultants and registrar during your rotation, so please remember to ask for help as required. Teamwork and strong team spirit is essential to manage the workload and pressures. Please enjoy your oncology rotation, and we will again extend a warm welcome and hope you have a very enjoyable experience working for us. Thank you.